Hey everyone, it's Sarah, the registered nurse, RN.com, and today we're going to talk about Thiazide Diuretics. And as always, after you watch this YouTube video, you can access the free quiz that will test you on this medication. So let's get started. As we've been reviewing these medications in this pharmacology series, we have been remembering the word nurse because each letter of that word helps us remember those important concepts we need to know for exams. So first, we're going to talk about the name, specifically the family name of the drug, because this tells us how the drug works on the body. And we're dealing with the thiazide family, specifically those thiazide diuretics. Well, thiazide tells us that this medication works in the early part of the distal convoluted tubule that's found within this nephron. And what this drug is going to do is it's going to affect a cotransporter that's found within this early part of the DCT. And this transporter is called the sodium-chloride cotransporter. And it is considered a thiazide-sensitive transporter, so hence why this drug works so well. And what it's going to do is it's going to prevent this transporter from being able to do its job. And just as its name says, is that this transporter transports sodium and chloride from the filtrate to go back into the blood to be reabsorbed by the body. Well, if we're stopping this process of this sodium and chloride going back into the body, that means it's going to stay in this filtrate, which eventually turns into urine when it exits the body. So if we have sodium and chloride staying in this filtrate, it's going to result in increased sodium in the filtrate, which is going to draw water to it because water loves sodium. So more water will stay in this filtrate, will not be reabsorbed back into the body, less of it will be. And this is going to cause the person to have increased urination because we have more fluid in the urine. So we're getting those diuretic effects that this drug does. And this will help slightly decrease our blood volume because we're removing it. Now, thiazide diuretics are not as potent or as powerful as loop diuretics like furosemide. And the reason for that is because each type of diuretic that you have is going to affect different structures within this nephron, which is going to alter how sodium is reabsorbed back into the body. Because if we keep it in the filtrate, that means water is going to stay there, and that's going to help provide that diuresis effect. So, for example, loop diuretics, we learn work in the loop of Henle, and specifically this thick ascending limb. And this thick ascending limb is responsible for about 25% of sodium reabsorption. So if we throw on a loop diuretic, we're not going to be reabsorbing all that sodium. It's going to stay in the filtrate. That's a high percentage of sodium, so it's going to have a stronger effect by keeping water in it compared to this distal convoluted tubule, where it only accounts for about 5 to 7% of sodium reabsorption. So you can see the percentage differences and why loop diuretics are a lot more effective than a thiazide diuretic. But the thiazide diuretic does provide a nice diuresis effect, but not as strong as a loop diuretic. And another thing about thiazides is that they're less effective in patients who have a compromised GFR, a glomerular filtration rate, meaning that this glomerulus of this nephron is not very effective in filtering the blood. And with loop diuretics, they are good in patients who have this compromised GFR, like they have renal failure. Let's say you have a patient with renal failure who has fluid volume overload. Well, we can give them a loop diuretic and that can help remove that fluid. But with a thiazide, we wouldn't want to do that because their GFR is compromised. And some examples of thiazide diuretics are like hydrochlorothiazide, indapamide, chlorothiazide, metolazone, and chlorothalidone. And unfortunately, we can't go by their ending like with some of the other drugs' generic names, but some do end in thiazide. Now let's talk about how these thiazide diuretics work on this nephron to cause diuresis. But to do that, let's review the basic anatomy and physiology of this nephron. Here's an illustration of a nephron. If we took a nephron and stretched it out, it would look something similar to this. Also, you can see how the nephron sets within the kidneys. And these structures work within the kidneys to allow them to function. And without them working properly, the kidney fails to do its job. And there are millions of these little nephron structures within each kidney. And they function to filter the blood and manage the amount of water, ions, and waste in the blood. And either it's going to cause some ions and water to be reabsorbed back into the blood so you can use them, or it's going to make it where the ions and specifically waste and water will stay in the filtrate so it'll be excreted as urine. So these little structures are always tweaking this filtrate that's created by the glomerulus until it's where your body needs it to be, and if it's not, you excrete it as urine. And the nephron is divided into several parts, and each part has its own unique role for tweaking this filtrate, which is why certain diuretics work on certain areas of the nephron. And the parts of the nephron include the afferent and efferent arteriole. The afferent arteriole delivers blood via the renal artery to the nephron so it can be filtered. The efferent arteriole takes blood away from the nephron after it has been filtered. So when the nephron receives blood through the afferent arteriole, it's going to go through the glomerulus, and this is going to filter the blood and create the filtrate, which will eventually exit the body as urine. And the filtrate is going to contain ions, which are like electrolytes, water, and waste. And it's going to drip down into Bowman's capsule, which will collect the filtrate as it drips down from that glomerulus. Then the filtrate is going to start its journey of being tweaked by the other parts of the nephron to the point where the body is satisfied with it, and what it doesn't want, it's going to be excreted as urine. So the first stop is the proximal convoluted tubule, and this area is going to reabsorb water, ions, etc. And the parts that we've talked about up to this point hang out in the renal cortex of the kidney. And this provides like an isotonic environment where the sodium concentration is equal in the inside, hence the nephron and that filtrate, compared to the outside. However, as this filtrate starts progressing, going down into the loop of Henle, it's going to enter into a hypertonic environment because it's in the renal medulla. And this is very necessary for water reabsorption by that descending limb of the loop of Henle and the collecting duct. So once it leaves the proximal convoluted tubule, it's going to go down into the loop of Henle, and the loop of Henle has the descending and ascending limb. So it's tweaked there as well. And remember, I talked about how that thick ascending limb is responsible for about 25% of sodium reabsorption. So the filtrate's going to go up, and again it's going to enter back into the isotonic environment, and it's going to go into the distal convoluted tubule. And this is the structure that we care about for this lecture for the thiazides, because this is where the thiazide diuretics work, specifically in that early part. And some functions of this distal convoluted tubule is to, of course, reabsorb sodium and chloride, but it also plays a role in reabsorbing calcium. And I want you to remember that, because one of the side effects of thiazide diuretics is that it can increase calcium levels. And also it plays a role with secretion of potassium into the filtrate. Then it leaves the DCT and it's making its journey to the collecting ducts. And this is the last part of the nephron where the filtrate is finally tweaked. Ions and water will be reabsorbed, and the last part of the collecting duct is found in that renal medulla, and this will play one last role with that water reabsorption. Then it will exit the body through the renal pelvis, and you will have urine, which will go to the ureters and be urinated out. Now let's go a little bit more in depth to how these thiazide diuretics work in this distal convoluted tubule and tie it in with why you're going to see these certain electrolyte imbalances for these patients. And these are some important concepts you want to remember for your exams because it'll tie in with your nursing interventions and your patient teaching. So we've already established that the distal convoluted tubule is going to play a role in us reabsorbing sodium and chloride and calcium and the secretion of potassium ions as well back into this filtrate. So the distal convoluted tubule, when we throw a thiazide in, it's going to affect this cotransporter, the sodium chloride cotransporter. It's going to prevent it from allowing these sodium and chloride ions from leaving the filtrate and going back into the blood and hanging out in the blood and keeping those levels nice and stable. So because we're not going to be receiving that sodium, we are going to potentially lower the sodium levels in the blood, leading to hyponatremia. So that's one electrolyte imbalance you want to watch out for. Now, because we're inhibiting this cotransporter, it's going to alter how these other channels and transporters can work within this distal convoluted tubule to deal with other ions to be reabsorbed. And one ion reabsorption that's going to be affected will be calcium, because it is affected by a particular channel known as the TRPV5 channel. And because we inhibit this sodium chloride cotransporter, it's actually going to enhance how this channel works. So it helps the body reabsorb calcium back into the blood. Well, if we're enhancing how this channel works, we're going to be reabsorbing more calcium in the blood, which can lead to hypercalcemia, increasing our calcium levels in the blood. A normal calcium level is about 8.5 to 10.5 milligrams per deciliter. Now, this can actually be beneficial, and we're going into a little bit for what this drug is used for, but patients who have recurrent renal stones that are composed of calcium can actually benefit from this, because if we are increasing calcium reabsorption from the filtrate to go back into the blood, that's leaving less calcium in that filtrate, which leaves less calcium that can help create a renal stone. Also, patients who have low calcium levels, we can possibly throw on a thiazide to help increase the reabsorption of calcium in the blood, which can hopefully help increase their bone density. So it can be beneficial in some instances, but as a nurse, you want to watch that calcium level. Also, thiazide diuretics can cause hypokalemia, and that was similar to our loop diuretics. They also can lower the potassium levels, so they share that. And why is that? Same like with loop diuretics. As this filtrate travels through this distal convoluted tubule, here in the early part, we prevented that sodium from being reabsorbed, so more is hanging out in the filtrate. Well, it's journeying down through the rest of this tubule, well, it's high in sodium. And these channels are influenced by aldosterone. And we've learned that aldosterone causes the body to keep water and sodium in exchange for potassium. So if we have a lot of sodium in the filtrate traveling down through these aldosterone influenced channels, that's really going to cause the body to secrete potassium into that filtrate, which is going to lower our potassium levels. And also going with that potassium is hydrogen ions. So we can lower our potassium levels, and normal potassium levels about 3.5 to 5 milliequivalents per liter. And the patient could possibly experience metabolic alkalosis due to the loss of those hydrogen ions. So remember that, and patients may have to take potassium supplements. You'll want to be watching that potassium level for sure, especially if they're on other medications, which we'll talk about here in a moment, and educate them about foods that are rich in potassium, and they want to definitely keep those in their diet. Thiazide diuretics can also alter the blood sugar, and this is important to know for your patients who are diabetic. Thiazide diuretics can increase the blood glucose level. The reason for why they do that is not truly understood, but we want to educate our patients to monitor their glucose level closely, because their insulin or their oral diabetic medications may have to be tweaked based on if they're getting this hyperglycemia. And thiazide diuretics can increase uric acid levels, which can lead to gout attacks. And the reason for this is that these drugs alter how the proximal convoluted tubule deals with urate, and it actually increases how urate is reabsorbed, which can increase uric acid levels and lead to gout attacks. So you may need to monitor those uric acid levels, and high uric acid levels for a male tends to be anything greater than 7, and for females greater than 6. So if you see a uric acid level of 15, that is not good. That means that they have high uric acid levels. So what are thiazide diuretics used for, which is the second part of our word of nurse? Well, they can be used to treat hypertension, high blood pressure, and they're usually about the first line for helping a patient treat their high blood pressure. And what it's going to do, it's going to decrease that sodium and water out of the blood, which can help lower the blood pressure. In addition, they can be ordered for patients who have heart failure. This is where the heart is weak to pump blood. It becomes really overwhelmed and blood starts backing up into the lungs and to the body, and the patient is really just miserable. So what these medications can do is they can be prescribed a lot of times with ACE inhibitors, and we talked all about ACE inhibitors, and this can help actually increase the function of the heart and help the patient feel better. Also, as we've talked about, thiazide diuretics can be used in the treatment of renal calculi, which are those renal stones that are composed of calcium. Now let's wrap up this review and let's talk about nursing responsibilities, the side effects, and education pieces for the patient who may be taking a thiazide diuretic. So whenever you have a patient taking a thiazide, you really want to be watching out for signs and symptoms of dehydration, because we're increasing their urination and how much fluid is being removed from their blood volume. So some things as a nurse you can watch out for is you can look at their vital signs. How is their blood pressure? If it's hypotensive, low, that systolic's less than 90, that probably means that we've removed a little bit too much fluid volume from their blood. Also, the heart rate will be increased as well, where it's tachycardic, from where that heart's trying to compensate for that loss of fluid volume. Then we can also look at their I's and O's. You want to make sure you are strictly measuring that, and the patient can help you with that if they're alert and oriented, and whenever they go to use the bathroom to urinate, you definitely want to make sure you are measuring that, because you want to look to see how much they're taking in versus how much they're putting out. If they're really not putting out anything at all, their renal function could be compromised. So we want to make sure that we are diuresing them, but not too much. And we can look at their daily weights, where we weigh them every day at the same time using the same scale. This tells us their fluid status and really tells us how effective this medication is working, because if they're gaining weight instead of losing weight, we may be not very effective with this diuretic. They may need something else. And you want to teach the patient to weigh themselves. A lot of patients with heart failure may be on these medications, and we want to teach them to weigh themselves every day and to write it down and to keep track, because if they've gained more than like 3 pounds in one day, that could mean that they're retaining fluid and they may be having heart failure exacerbation and will need to go to their doctor to get treatment. Also, as a nurse, we want to monitor their labs, because as we've learned, these drugs cause electrolyte imbalances. So the physician will order the labs, we will get those results, and we will look at them. You always want to look into results, especially before you give their medications, because electrolyte imbalances can induce like toxicity of other drugs. So we've learned that thiazides cause a lot of hypo and a lot of hyper conditions. So let's talk about the hypo. We know that it can lower the potassium levels, causing hypokalemia. And if your patient is on digoxin and their potassium level goes too low, it can increase the risk of digoxin toxicity. So always look at that potassium level and be educating your patient to be consuming foods that are rich in potassium, like bananas, avocados, strawberries, potatoes, etc., because that will help keep that level high. And a normal dig level, I just want to throw this in there, is about 0.5 to 2 nanograms per milliliter. The other hypo condition it can cause is hyponatremia, where that sodium level is too low. And that was another thing that lube diuretics did as well. It can lower it too low. So if you have a patient who's taking lithium, that's not good, because when sodium levels drop, if a patient's taking lithium, it can increase the risk of lithium toxicity. So a normal lithium level is about 0.5 to 1.2 millimoles per liter. So remember, these two drugs, if we go into these hypo conditions, either hyponatremia or hypokalemia with those, it can cause toxicity. Those are some important concepts that I know exams love to ask about. The hyper conditions that these drugs can cause are hypercalcemia, that high calcium level, hyperuricemia, the high uric acid level, and hyperglycemia. And again, teach your diabetic patients to monitor their blood glucose really closely while taking a thiazide. And some other little miscellaneous things you want to remember is that whenever you give a patient any type of diuretic, they can get up and use the bathroom on their own. You need to make sure they have easy access to it because you don't want them to fall and get hurt. And avoid giving doses of diuretics at night because we want our patients to sleep at night. We don't want them up using the bathroom all the time. So make sure you're not doing that. And orthostatic hypotension. This is where when the patients, maybe they've been sitting or lying down, they get up, they can fall, they become dizzy. You want to teach them to change positions slowly because we're altering the fluid status in their body. And as a nurse, you want to make sure that this medication is being effective. Is it doing its job? How do their lungs sound? Is their blood pressure coming down? Maybe they're getting this drug for hypertension. How is their weights? Are they gaining weight or losing weight? So we play a huge role with that as well. Okay, so that wraps up this review over thiazide diuretics. Thank you so much for watching. Don't forget to take the free quiz and to subscribe to our channel for more videos.